Let's get together now and there's a reason why in many cultures siesta starts about now, but it's not part of our cultural heritage. The fourth and final panel for the day, it's tough to have a conference like this and have the day go long. Maybe there's lessons to be learned about scheduling. Maybe I should have gotten a 52-inch flat screen TV and told everybody there'll be a raffle at 3 o'clock, and if you're not here and you win, you can't get it. But it is what it is. It's okay. The last panel is a medical practice panel, and it's a very interesting panel because what you'll hear are actually they're both all of the thoughts and concepts you'll hear are committed to the same route, which is to help the patient, the elder. However, the question is, what route do you get to that same endpoint? So I'm going to introduce the panel chair today, Sam Lesko, Dr. Lesko. He's the medical director for the Northeast Regional Cancer Institute and the Regional Cancer Registry. He's an MD from Jefferson Medical, has an MPH from Yale. I could go on. It's an extensive, everybody I did. The most important thing is Sam is an epidemiologist, and that's yet another way to look at aging. Aging can be studied from an epidemiologic perspective. We can take a look how things vector in and out. We can see what correlates with what. It's a macro view of disease that involves many, many people. We've been hearing about individual views of aging, and how when Dr. Ames was talking about how each of us can get our protein analyzed by going to a kiosk at Walmart. So this is a very special approach to take. He was a clinical professor in human evaluation sciences at Penn State College of Medicine. He's a member of the Penn State Cancer Institute, an adjunct professor in public health sciences at Penn State, and an adjunct professor in basic sciences at the Commonwealth Medical College. So, like all the other panel heads and panelists, we really have some wonderful people, and I'd like to welcome Sam and say thank you for chairing this out. I was going to use the word iconic, but I'm afraid, because I'm not quite sure what that means.
Thanks for the introduction, Herb. I'm not sure that Dr. Ames would agree that it's good to be an epidemiologist. He didn't seem to care much for epidemiologic data, but he's probably out of earshot at this point. We do have 4 presentations in this session from folks dealing with older patients, and we're going to talk about a couple of very different issues in the elderly. There doubtless will be some overlap with some things we've heard of today already, but there are little different issues that we're going to address. And at the end of the hour, I hope it leaves us with an awareness there are plenty of unanswered questions about how we provide appropriate care for an aging population. Questions that, if we set our minds to, we can probably work on and develop research agenda to try and address, to answer some of those questions. That's sort of the big picture, at least for me. Our first speaker in this session is Mary Triano. She is a nurse practitioner, certified in advanced status nursing, and is a co-leader of the Institute for Palliative Medicine here in Scranton. And she'll talk about care near the end of life. Can we design a better system? So, Mary.
Oh, thank you. I have to say I'm filling in for Dr. Jay Vanston, who I work with, who is the other co-leader of the Institute of Palliative Medicine. He unexpectedly had to be out of town. He certainly wanted to be here. I want to thank everyone for allowing us to speak here. We have been working in palliative care for, I guess, the past 7 years, and the last 2 years have worked independently in Lackawanna County, taking care of not just the elderly, but people with chronic illness and people towards the end of life. And one of the things that we've come across is the fact that our current system of care really doesn't work, particularly for the elderly population. So one of the things we've talked about a lot, and we've done some research and looked into the research at, is, what is a better design for the elderly at the end of life, and what are some of the breaks in the system, and where, as a community, can we do better? Unfortunately, a lot of what we've come to is more questions than answers, so this is the right group to be speaking to. One of our heroes is Joanne Lynn, who many of you know from the support study from the 90s. Joanne Lynn and her researchers have looked at illness as populations now. And so what she has done is looked in a landmark study recently and looked at people as populations, and actually has turned things as a different paradigm. And so she's looked at the population overall, the big picture, and has said, if we look overall and we look at who we're dealing with, the population as a whole, the chronic conditions, people with end-stage heart disease, end-stage COPD, that's 110 million people that we're talking about across this country. It's a lot of people. People with stable disease but serious disability, you're talking about 7 million people. And for the sake of time, I'm not going to talk about the healthy and the maternal and infant health, but our hospitals are set up to deal with the acutely ill. 12 million people fall into those categories, and our hospital systems do a good job with the acutely ill. But it's the big number, 110 million people with chronic conditions, that our systems that are currently in place don't really do a good job with. When we look at those people that are needing care near the end of life, we're talking about 1 million people that have a short period of decline before they're dying. People with chronic heart disease, chronic COPD, limited reserves, have exacerbation of disease that are coming in and out of the emergency rooms, have short stays in the hospital, in and out of nursing homes for what we call rehab services. That's 2 million individuals. And those, probably the biggest burden on our society in terms of we really don't know how to care for them appropriately, are those with frailty, with or without dementia. We're talking about 6 million people. And if we look closer to home, I'm going to go forward a minute, and if we look at Lackawanna County, data from 2010, 40,000 individuals in this county are greater than age 65. If we look down closer at that, we've got 20,000 individuals that are greater than 75. If we take that data, extrapolating from that data, 3 to 5% of those are near the end of life. So we've got 1,200 to 2,000 people that fall into one of these end-of-life categories that are going to need care. Those are not the people that should be coming into our emergency rooms. Those are not the people that our current systems of care do well with. And unfortunately, we've got this really tough problem now where systems of care like hospice, there's so much scrutiny on hospice care now with Medicare, that so many of our people at end of life, hospice says they're not sick enough for hospice. They're not symptomatic enough for hospice. So they qualify for hospice, but not in an inpatient setting, and then they need to go into a nursing home again. So they're falling between the cracks of all the systems of care that we have. I want to go back for a minute. So if we look at that population, and these are the people that we deal with in palliative care all the time, what we need to think about is most people are going to develop a chronic condition if you live long enough to head into that elderly population. Almost every one of us will experience some end-of-life course. And return from one of the end-of-life courses like end-stage heart disease, end-stage COPD, or dementia is unlikely. And the transition from limited reserve to frailty is common, and we see it every day. To even get closer, coming down to the individual experience, I'll tell you about a woman that we just sent to a nursing home today from a hospice setting. She's a 92-year-old. Her son is in his 70s and lives out of town. Her grandson is a family practice physician who's in Connecticut. And she was living in a nursing home. She has pretty advanced dementia. She's severely hard of hearing and has very limited vision. Chronic COPD, some heart disease, basically is very frail. She ended up having behavior issues and ended up having to be transferred to senior mental health. Senior mental health gets a lot of medications, somehow or other gets into trouble with pneumonia, probably aspiration pneumonia, ends up with a rapid response problem. Into Moses Taylor Hospital, where she looks like she's going to have a respiratory arrest. They don't resuscitate her. We get involved, transfer into hospice care. Moves to hospice care, and with the right nursing care, I always say more nursing, less medicine, she resurrects. And now she is too good for hospice care. And off she goes back to the nursing home, where because of the financial considerations, she's going to be quote-unquote skilled, and now she's off the hospice benefit again. And she's cycling right back through the system. And we all know what this woman needs. She needs to be somewhere safe, where no one's going to do anything else aggressive for her. Her family wants her to be comfortable and safe in a setting where people are going to, as Dr. Pinchas said, her family that's going to be around her is going to care for her with dignity and respect, where she's going to feel safe, and that she's going to live out her days comfortably. But it's really hard, even if we know what's the right thing to do, to get her there, to have her stay someplace, and put those things in place where she doesn't end back up in a system that isn't the right place for her. And I understand where in a nursing home, if she's in trouble, they're going to put her back in the hospital. And hospitals do what hospitals do. They do aggressive things. And this cycle starts again. And it's unfortunate, but we have to do a better job as a system to intercede for this woman and be advocates for her. I just put this up here. A lot of people have seen this trajectory of disease, but people with end-stage heart disease and end-stage lung disease, and of course Dr. Stahl can speak to this more, but these are people that you talk about kind of the end stage of their life. This can go on to 2 to 5 years. So it's a long time that can get into this cycle where they're going to need help, and they need a system of care that can take care of them over time. So you can see where they can get in trouble in the current systems that we have in place. Here are the people that we can really have a problem with. People with frailty, with or without dementia. These are people that where's Sam? These are people with dementia with or without frailty. They can have 6 to 8 years from onset of their dementia till death. What we do know is when they come into the hospital with aspiration pneumonias, when that starts, or UTIs, there can be, we now know there's maybe a 2-year time period from those recurrent aspiration pneumonias and UTIs till death. But these people need a lot of care, and we need good nursing home or support for families if they want to keep them at home. And that's a real burden to the families and the systems that are in place. So where do we come in as a palliative care service? We are, in many respects, we're the death panel everyone was talking about. What we try to do as we move through the acute care system, as we move through the hospice units, and as we see people in outpatient settings, one of our main roles is to provide pain and symptom management for patients along the trajectory of disease cancer patients, also people with COPD, heart disease, and also dementia. But along with that, one of our primary roles is to help patients and families clarify the goals of care that they have, and to try to help them have their plan of care meet their goals. So many times we'll meet a family and a patient in the ICU, and when we sit down and we say, what are your goals? What are you still trying to do? And where do you still want to be? We can help sort that out. And it may be they're in the right setting. It may be they're not in the right setting. So we can help kind of sift through that and help patients get the right care that they want at that time. And sometimes, it takes a number of times through a system before they can clarify their goals, and other times it's a little clearer for families. The other big role we have in palliative care is to help navigate the healthcare system so that our vulnerable people at end of life do receive the same quality care at the appropriate level in the appropriate setting. And when I say that, I truly mean the fact that we need quality hospice care, we need quality nursing home care, so that patients at end of life receive the same high quality standards that we expect from the acute care setting. And often we see that there aren't the same standards at that part of life that we see in the acute care setting. And we really have advocated for the same level of high quality standards all the way across the board. What we put out there for an entire group, and this is a great setting to it, is certainly northeastern Pennsylvania has a growing population of individuals near the end of life. We know that the current system is extremely fragmented, and it can often be ineffective for many patients like the one I described. We clearly need to work on our systems of care so that patients can be in the right setting at the right time with the highest quality of care that they deserve at the end of life, and that the systems are more streamlined so that we can avoid patients at end of life getting in the wrong place, more for the reasons that Dr. Pinches described as the fact that we want to honor our elderly and have them treated with respect that they deserve, and that we get quality care for them right to the end. And so our challenge is out there. I think the issue of symptom management, pain management, that's the easy part. The hard part is getting our people in places where they can be safe and they can stay where they want to be. And that's the more difficult part.
Thank you, Mary. What I'd like to do here is hold questions till the end. I'd like all of the speakers to present. They'll come up to the front, and then we'll be able to take questions as a group. So our next speaker is Dr. Russell Stahl. He is a physician, cardiothoracic surgeon, trained at the University of Pennsylvania Hospital in Philadelphia in cardiothoracic surgery. He is the chief of that section at CMC and has a clinical faculty appointment at the medical college. And the title of his presentation is Anyone Too Old for Heart Surgery? Thanks, Russ.
Thanks, Sam. And it's appropriate that I follow Mary, because usually I go just before Mary and Jay. I tell Mary and Jay I'm the pre-palliative care consult, because those folks that are in that declining state often are discovered to have heart disease. And then I get a consult, and I say, really? And so often you have this discussion, are you a candidate for surgery or should you shift directions? You know, I'm often the first one to say, they've come all the way down this line, should you shift directions and start headed towards palliative care? So I have no financial disclosures. I do organize a local symposium, Convergence Around Technologies for Cardiovascular Health, and some of this material we've talked about there. And I'm now part of the Geisinger Health System, which I'm happy. It's at one stage in your life you've been looking for something, and then that something finds you a more integrated, value-driven health delivery system. So I think it's a fortuitous time. So why are we going to talk about this? Well, it's a paradigm. You folks all know. Burgeoning elderly population consuming a lot of healthcare resources, and heart surgery can just be a paradigm for that. This expensive, high-tech medicine, where do we draw the line? Where do we stop? You all know about the healthcare debate. It's going to reach a peak again now. Mike was talking about the Affordable Care Act, and is that going to withstand the rigors of politics? But part of that, a small part of that debate is, do we spend too much in the last year of life? To which I answer, please tell me when the last year of life begins for a person. I'd be happy not to spend too much money on them from that point on, if you could just let me know. And, you know, the illusion that, or the comment that maybe we can find some common ground for research, I think this is where it is for me, and based on what I'm about to tell you, is if you can show me better metrics to know how far people are along that continuum that Mary just showed, that decline if they're in the chronic illness category, that would really help me decide. So really, from my perspective, which older folks deserve the treatment that we're talking about? Whenever we talk about healthcare in the elderly, particularly heart surgery, it raises these isms or issues, if you will. Ageism means an inherent prejudice based on age. If people used to say, well, if you're over 80, you don't get heart surgery. Well, we know that's not true. Your physiologic age counts a lot more than your chronologic age. So that would be an ageism. Very often when I'm asked to see the older folks, and when I say older folks, I usually mean 80 and older, but for some of my data I'll show 75 and older because that's what we have available. But when I'm asked to see those folks, usually the kids are speaking up, which is good. We want the family there. But when they speak for the other person and rob them of their autonomy, I call that paternalism. Someone else is going to decide for you. And then this issue of rationing comes up, and all healthcare systems have rationing. And that means we're going to distribute the healthcare based on policy, and therefore somebody will do without the healthcare if you decide it that way, which is not necessarily wrong, but that these issues come up when we talk about doing heart surgery on the very old. And you've been talking about this all day, so I'll breeze through this quick. You know that the aging population is rapidly growing. By 2050, those 85 and older will be 2% of the population, and we'll have more than 1 million people who are over 100. That's the fastest growing segment of the population. And what do we know about these old folks is they consume a lot of health care. Is there a pointer anywhere? No?
Use the mouse.
Oh, okay, is there an arrow? Oh, there it is. Okay, so you can see those who are 75 and older have visits, much more likely to have 10 or more visits a year. That would be the red bar. And most of these visits are for these chronic conditions that Mary alluded to: coronary disease or ischemic heart disease, valvular heart disease, and heart failure. This is the prevalence of these cardiovascular diseases in Americans by age and by sex. And you can see by the time they get to be 75 and older, about 80% have one of those chronic conditions, mostly hypertension, but along with that, the sequelae of coronary heart disease and heart failure. Very common. And this is from I'll mention the STS a few times. Society of Thoracic Surgery has the largest clinical database for any specialty in the United States. Heart surgeons were a little ahead of the curve in starting this voluntary database 25 years ago. So this is the percent of patients who are having valve surgery in that database, and you can see when you get to the older groups, it's the increasing proportion of valve surgery. I would say this data is not current because coronary artery surgery keeps going down in the U.S., and so therefore the portion that are having valve surgery goes up. And we're operating on more and more older folks, particularly those elderly females with aortic stenosis would be a good example. This is my aunt and my uncle, shortly after World War II, just back from the war, 20s, mid-20s, getting married at that time. Why do we operate? Well, the only two reasons that I recommend surgery to people, it's either to relieve symptoms or prolong life. And so here they are, 60 years later. Uncle Herbert, at age 84, had aortic valve replacement. My cousins called me up. He said, "You think we should do that? He's 84." I said, he's a pretty sturdy guy. You should go ahead. We got together last summer in Houston to celebrate his 90th birthday. Aunt Ruth passed away from chronic disease in the interim since that picture. So when we go back to the prolonged life issue, can you get any bang for your buck? This is for the health policy folks. Bang for your buck means, is it a good return on investment to invest all this money in operating or taking care of the very old? And I think that depends on what their life expectancy would be under ordinary conditions without disease. Can we improve that longevity by intervening? And then the symptom issue, quality of life, and then some folks like to talk about dollars per quality adjusted life year. I don't know if that concept was touched on earlier today when you're talking about health policy or expenditures, but that's an interesting concept. So you've probably reviewed this. The average life expectancy of an 80-year-old is about 8 or 9 years. And that of a 90-year-old is close to 5 years in the US. This would be survival curves for patients having aortic valve replacement, those who are 80 or older. And you can see that this lower graph is those who are 80 to 89, and if they get through their surgery, they are put back on a pretty normal trajectory. Their median survival is 7.4 years. I told you the average life expectancy for an 80-year-old. An 80-year-old is 8 to 9 years. So this combines people who are 80 and above. So if you get through heart surgery, you're back on your trajectory. Maybe you are getting some bang for your buck. Depends on what you think is worthwhile in terms of healthcare dollars. The same is true for coronary bypass surgery. And you can see those who have CABG or isolated valve, if you take them out 5 to 8 years, their survival looks a little better. The straight line is the average life expectancy of those folks. If they have more complex surgery, by definition, worse heart disease, more likely to have heart failure, valve CABG, our highest risk population that we operate on. But also notice that little dip below the curve early on, and that represents the rigors of surgery and the complications. So you get my point that if they survive surgery, you put them back on the normal life expectancy curve. But not everybody survives surgery. And the reason is that some suffer some pretty bad complications after conventional open heart surgery. And it's clear that the elderly suffer more adverse outcomes, they consume more resources, more likely to be transferred to long-term care if we do heart surgery. So really, to experience a net benefit, you have to avoid these major post-op complications. And that's where I have sometimes trouble discerning who will and who won't. This is from that Society of Thoracic Surgery National Database, and this is I chose the CABG model because they had the largest number of patients. You can see that there's 750,000 patients altogether, over 170,000 who are beyond the age of 75, and that represents 22% of the population in this harvest of the database, this look at it. And you can see that the mortality for coronary bypass surgery, those over 75, is more than twice that of the overall population. You can contrast it with those who are younger. You can see that their risk of stroke is high, renal failure. This stands for prolonged ventilation time, more than a day in the ICU on a ventilator. Deep sternal wound infection, these are all the risk-adjusted outcomes that are tracked in our large national database. This reoperation, total complications, suffered any complication, you have 21% for the elderly, contrast with the rest of the population. And this is prolonged length of stay and short length of stay. There's definitions for that. If you're in the hospital for more than 2 weeks after heart surgery, you fall into the prolonged length of stay category, considered to be an adverse outcome. So you can see that for those who are 75, more likely to have complications, more likely to stay in the hospital, more likely to consume resources, and more likely to die. Sam had asked me to include some of our data, so I had done this a couple of years ago. This is for 05, for 09, for our now Geisinger Community Medical Center. And this would be CABG valve and valve CABG patients. This would be our mortality rates for those. And you can see that we're better than the STS national database average. We're better in the observed to expected categories. And I'm not going to talk a lot about why I think that is, but you have to know your own outcomes before you recommend surgery to patients. You have to say, in my hands, in my hospital, this is what I expect. All patients get informed consent. I tell them exactly what I think their risk of dying, their risk of being on a ventilator for a long time, their risk of losing the ability to live independently. That's the most important thing to the old folks. Most of them are not dissuaded when you say you could die from surgery. They're old, they're near the end of life. They accept that. But if you tell them they're going to have a stroke, they really perk up. If you tell them that they won't be able to go home and live in their own home anymore, that gets their attention. We took a more recent look at aortic valve patients who were those who are over 80 and those who are less than 80, and we have similar, actually better mortality rate in the elderly there. But you can see some of the things such as stroke are higher, the time in the ventilator is higher. And we've moved towards less traumatic surgery. I'm going to talk in a minute about transcatheter valve, but I try to do as many isolated valve operations as possible through a small incision, less invasive or less traumatic surgery, with an eye towards minimizing these postoperative complications. One of the reasons we're better is we pay close attention to kidney injury and blood transfusion. You can see those who were over 75 who did not receive blood had essentially no mortality. This is their actual versus their predicted. And those who received blood transfusion were just a little less than predicted. So we think working hard on blood transfusion is an important aspect of this. And the elderly are very likely to be anemic. They come with a lot of comorbidity. So you have to work those things out before surgery. This is back to the resource utilization. Those who are greater than 75 are more likely to stay in the hospital. This is their overall length of stay, and this is their postoperative length of stay, particularly in those valve CABG patients who are more likely to be heart failure patients. You can see there's a significant difference in their hospital stay. And this is the dollars that it costs to care for them during that episode of care. This is not charges, these are actual direct costs that are attributable to the patient. And the reimbursement, by the way, for the hospital is the same whether you're more than 75 or less than 75. So if you're a hospital administrator, that's eating into your margins there if you choose to operate on the older folks. Well, what are the alternatives? You don't have to do surgery. Medical therapy, by and large, is poor for the conditions we're talking about. It doesn't relieve valvular heart disease. You know the story on congestive heart failure. The patients come, it's most likely to be readmitted, most likely to wind up in the hospital. Catheter-based interventions are a less invasive technique, and then there's less invasive surgery, like I alluded to. What's coming on the scene here in the United States right now, it's been available in Europe for a few years, is transcatheter aortic valve insertion, or Tavi. Some people call it TAVR for replacement. But here's an example of, through a small-ish incision, you have a valve on a stick or on a guide, and you deploy it there. It just smashes the old valve out of the way, and you open up a new valve there. This is the valve here. This is a transesophageal echo probe to look at the heart while we're placing that. These are the results of the clinical trial, largest one, landmark study. These are patients who were deemed inoperable by surgeons. These are really old, really fragile patients with high predicted morbidity and mortality scores. So they were randomized to the so-called cohort B of this trial, inoperable patients. This is the absolute mortality. So 50% of the non-operated patients were dead within a year. 30% of those had a transcatheter valve. That's an absolute difference of 20%, which is a huge difference in clinical trials. And I don't know if you look at some of the studies with drugs and other devices, but a 20% absolute difference in mortality at 1 year is enormous. And based on that alone, the FDA approved this technique, this device in the US. It does come with some complications. You have to stick these devices in through peripheral vessels, so vascular complications are high. And when you smash that valve in there, some debris travels downstream, and stroke is a higher risk in those patients. The A cohort were those who were thought to be operable but at high risk. So we looked at not we, but the authors of this study looked at transcatheter versus conventional surgery, and they found only modest improvements, different types of complications for the transcatheter versus the traditional surgery. Traditional surgery associated with bleeding in these elderly folks, close to 20%. So less invasive techniques are coming on board, which means it opens up the door for more patients to be evaluated, more very, very elderly patients. Our traditional risk scores capture the well-understood parameters, the renal dysfunction, hemodynamics, but there's a seductive appeal to these transcatheter techniques, expanded population of very old people. And debility caused by severe symptomatic aortic stenosis is difficult to untangle or separate from underlying frailty. So I'm at the Society of Thoracic Surgery meeting, and they're talking about frailty. They're teaching all the surgeons, okay, how do you measure how old is too old? What constitutes inoperable? As most of you know, there are indices, metrics, semi-quantitative scores to measure how frail a patient is. These are 5 important ones: unintentional weight loss, poor grip strength, reduced energy level, slow walking speed, and a low level of physical activity. If a female over 69 has 3 or more of these, she can be defined as frail. Increased likelihood of falls, disability, death. And the simplified version that your physical therapist might know is the timed up and go test. Ed Dieslak taught me this a couple of years ago. The patient sitting in the chair, you ask them to get up and walk 15 feet, turn around and go back. They now have this as a metric in the Society of Thoracic Surgery database, a 5-meter walk. You time them, right? And I don't know what the cutoff time is, maybe, January, 6 seconds or something? We have to time ourselves and see if we can do this. But yeah, I think. But when you think about it, it's a functional status. Very often when I'm in the hospital and they say, you know, she was really good until she got sick and she came in. She was doing everything at home. And then I find a person who looks to me like they can't get out of bed. And I'll say, if I could see you walk in the hall, I probably would operate. But I got to see you walk in the hall. And this is part of the whole preparation bit, which I left out. This is not about how to do the surgery and how to get the folks through, but they got to have a little reserve in order for you to do surgery on them. So as surgeons, we're starting to learn and think about who is too old, who is too frail. And I think the next speaker is going to help touch on some of the cognitive issues, not for the surgeons, but for old folks in general. And you all know about the risk of falling. Each year, 1 in 3 elderly fall. They're responsible for a lot of admissions to the emergency department. 1% die from falls. 50% of women over 85 have fallen. I start to ask my patients this question. I'm surprised. I was shocked when I learned this. I said, have you fallen? And the answer is, what do you think the answer always is? Yes, but it was just, I stumbled. It was, my daughter left the thing out and I tripped over it. I just got to, and you're like, really? Well, has it happened more than once? Yeah, there was the other time. And then the kids piping. Well, there was a time, Mom, we had to pick you up outside the house. Remember that one? And, they may have been evaluated in the ER. Some of them have aortic stenosis, so they may have had syncope, which is a symptom of aortic stenosis. But when they fall, it's the beginning of the end. Think about it. Those who have fall-related hip replacement, half of them are falling again in 6 months. I wonder what the orthopedic surgeons think about this. This can't be good. 50% of the deaths due to injury in the elderly are from falls. 40% who are admitted to a nursing home for a fall never regain independence, and 25% of them are dead within a year. So to me, that's another measure of the frailty. Have anybody talked about the sarcopenia today? The term of you're losing muscle mass, you're losing strength. It's a vicious cycle. The less you do, the less you eat, the less you exercise, the less you have. So, sometimes I'm doing pre-op rehab to see if the patients have the spunk, the stamina to get through the surgery. If they're wobbly and they told me that they fall and they can't walk, I'm not likely to offer surgery. And then I always have to stop and ask the patients, because so often the kids or others, the nieces, the nephews, are speaking for them. And I have to sort of get them to stop offering all the information and say, let's let Dad talk, okay? What do you want? Well, most of them, they want control, especially if you get them before they get to the hospital. You have to talk to them when they're on their feet living at home. Most of them say, I would be hospitalized if I need it. Most, not only 60% would say, yeah, I think I would like to be resuscitated. Many don't receive care consistent with their wishes. Once they get into the hospital, that paternalism thing kicks in big time, and somebody else is doing all the talking for them. And that's a big issue with our rapid response teams and our code teams. The old person lost their say, and somebody else is saying, do everything for them. Octogenarians who are familiar with living will information usually make very reasonable decisions. 75% say, no, I don't want it. They don't want to be a burden. They don't want to hang around if they're going to be a burden to someone. 86% choose basic medical care or comfort only. They have a greater acceptance of death with advancing age. So their preference for life-sustaining treatment are affected by their physical and cognitive function and the perceived clinical outcome. Now this is back to Mary and me being the pre-palliative care. It is very easy to sell treatment to patients. It is very hard to sell no treatment. I am amazed how difficult it is when I say, I don't think this is a good idea. I don't think heart surgery is really going to get you where you want to go. I think I warm up to it. I don't hit him right over the head, but I warm up to it. I think Dad's going to be gone in a year no matter what we do. You sure you want to spend the last few months of life, going through heart surgery, recuperation, all those risks involved? And they say, we're going to do nothing? And it's really a tough sell. My heart goes out to Mary and Jay. Whereas if you offer treatment, they will always take it, always. So faced with permanent loss of functional independence, elderly patients really curb their appetite or their willingness to undergo treatment if you give it to them straight. So help me figure out, let's design the research. Who's too old? Should we wheel them into the OR, or should we just take them out and shoot them? So I assess, I look at the physiologic function. We're pretty good at measuring the cardiac function. That's what we do. I get all the data. I got the echo, I got the cath, I got the ejection fraction. I know all the details. Other organ systems, pretty good. If you graduate from medical school, you can sort of deduce heart, kidney function, lung function. The cognitive function, we're not very good at. Please help me. And then the measuring the frailty thing, we're just scratching the surface of it. My rule of thumb is if the best possible outcome is transferred to a nursing home, I usually do not operate. If my goal is to restore people to health, get them back on that life expectancy curve. If they're living at home, that's what they want to do. They want to go home. So in summary, there's decisions regarding healthcare for the elderly, including high-risk cardiac surgery, are going to become more and more frequent. No getting around it. I don't know when the last year of life begins. Every decision is individual and important. There's no blanket policy. You can't say anybody over the age of such and such should not have surgery. And some teams are more successful than others because they pay attention to the details. There's a lot of details. I kind of like the old people. I feel most like a doctor when I'm helping the family decide should the older folk go ahead with this surgery. Or you could be like Peter Townsend and just say, okay, thanks guys.
Thank you. Very good. All right. Next presentation is on dementia, or delirium, sorry. But most importantly, the speaker is Margaret Zalen. Dr. Zalen is a member of the faculty at the university here. She's a full professor in the Department of Nursing and teaches adult health, leadership, and research. She's also the chair of the IRB. So when we had that earlier question about ethics, it would have been good to have you here. But you're here with us now, and we're anxiously waiting to hear your presentation on a transdisciplinary collaboration as a strategy to facilitate complex care management. Welcome, Margaret.
Good afternoon. I don't have the benefit of being here most of the day because my employer likes me to show up to teach occasionally. But actually, what I wanted to talk with you is what we're doing here at the University of Scranton and some of the future activities and our focus on delirium. So first I want to say collaboration is important, and I think that's why this program is co-sponsored between the medical school and the university. But we have a document from the Institute of Medicine on Health Professions Education that indicates collaboration is key. And collaboration is important in the clinical setting. We have a lot of research going back 25 years or more saying that when nurses and physicians and other healthcare professionals work together and collaborate, we have better outcomes. Now we might say, well, we kind of know that, but as the saying goes, in God we trust, everyone else bring data. So the next step in looking at that is how can we collaborate in research? And that is also a very interesting process because I think a lot of times when people talk about collaboration, what I've heard colleagues say, oh yes, that means the pulmonologist is talking to the cardiologist. And so this fall, when I was invited to join our team here at the University of Scranton, our physicist said, oh yes, in my discipline, interdisciplinary means when the electrical engineer is talking with the physicist. And so it's been quite interesting to think about really reaching across disciplines and also reaching across researchers, partnering researchers and clinicians. So we know that cross-disciplinary teams are increasingly common in research. And actually, I just found this particular publication just out this year that Transdisciplinary Research Center grants have higher publication rates than traditional investigator-initiated grants. Now, we'd all like, the publication rates are very nice, but we're here today because we're very concerned about the elderly people in our community and in our nation and what we can do about that. So just review a little bit what I mean about transdisciplinary. It's really going across the boundaries of disciplines, but also partnering researchers with practitioners, because they are the people who have their ear to the ground. And it is the researchers that have the design skills and can work together and actually look at answering the questions. But it's the practitioners that help us to ask the right questions and know what's going on in a clinical setting that keep us grounded in what is really important. So I want to point out that we have a lot of scientific collaboration, and this is actually a graph that's done by this guy, Bo Shane, and it shows the cross-publication of people from different institutions. So, and he actually graphed them so you can see the United States, Europe, and Asia. So you can see where there are centers for where there's a lot of interdisciplinary across collaboration in scientific research. And so I'd like to share with you some of the work that we're doing in that direction, but with a focus on elder care and a focus on delirium prevention. Some of the challenges that we're facing are the heterogeneity in elder care, that we have primary care models largely created for a younger patient population. If you think of Kaiser Permanente and their initial HMOs, and they were looking at a younger population. The other thing that Mary talked about is how caring for an older population, a very sick population, requires care coordination so we don't have this cycling in and out of the systems. And the other thing is that actually our healthcare workforce is not terribly well prepared to deliver the best care to older patients. We have a publication also out of the IOM a couple years ago on retooling the healthcare workforce for an aging America, and how is that going to happen in terms of ancillary personnel, the educational requirements, and so forth. But what we're looking at here in Scranton and in Northeast Pennsylvania, where we have a higher population of elderly, is how we can really answer that one critical question that Dr. Stahl mentioned, is the person wants to live at home. And I've had this, patients in the hospital, they'll say they want to go home, and I look at them as like, well, you can't even get out of the chair without 3 people helping you up. How is that going to happen? And so the other thing is, there's the rehab for the person that's in the hospital, but also focus on what we can do to help people stay in the home and live independently. So some of these things are providing backup support and services, providing health monitoring, controlling things that an aging person might forget, such as leaving the stove on, and also timely communication to caregivers and healthcare providers. So we've put together a fairly large team, and I'm going to talk about grant proposal that we submitted this spring, or actually this winter in January, in the hopes of helping to accomplish that and help people stay in the home independently. And I'll talk about my concern in particular is I'm interested in preserving the cognitive abilities of the elderly. And also, I'm very much interested in delirium as a health problem. And delirium is a sudden change in mental status, as opposed to dementia, which is a slow cognitive decline. And many of our elders experience delirium when they come to the hospital. And in fact, many cases of delirium are elderly patients come to the hospital. That is what triggers their hospitalization. The other thing is, once they get into the hospital, they may experience an episode of delirium. It is a problem after surgery, either for hip fracture or for open heart surgery, and it's a very, very serious concern. The example I'll give you is a number of years ago, I was doing a study of post-op patients, and I was getting consents from the people prior to surgery, which is very different now because we now compress that and we don't have a lot of people coming to the hospital very much before surgery. But I had 7 people in that, over that course of that 3 months, who had fractured their hips and were presumably candidates for my study. I was only able to get consent from one of them because the other 6 were not capable of providing their consent. So it tells you that that's a critical problem, and I believe at CMC they're working on how to get those hip fracture patients in through surgery and out more quickly to decrease some of those consequences. In critical care, we know that 75% of our vented patients may experience delirium. Why is delirium important? Because it sets them on a path that may be very difficult to recover from. They're less likely to go home, back to their own home. They're more likely to go to long-term care, personal care homes. There's increased mortality. They are more likely then to have subsequent dementia. And then we also have a phenomenon of delirium superimposed on dementia. One of my partners in this on our team, I've been working with for some time, is Sonia Sandhouse, who directs the Hospital Elder Life program at Moses Taylor. This is a research-based program developed by Sharon Inouye, and it's based on using volunteers to provide low-tech interventions such as reorientation, feeding, distraction to the elderly, and also includes ambulation, although that's not something that Sunny does. But I work with Sunny, and we've done a number of projects together, and the work is really designed to prevent delirium because the research indicates that we need to intervene early, and we can do a much better job at prevention. The trials that have looked at delirium treatment have largely found that we don't have a lot that works, which is very unfortunate. So our project here is to look at how can we detect delirium very early. The point that I should also make here is that in the hospital, doctors and nurses don't do a very good job of detecting delirium. Clinicians are very busy, and it takes a little bit of time to detect delirium. The other thing that is a characteristic of delirium is that it fluctuates. So you might walk into somebody's room and they don't exhibit any symptoms of delirium, but later on they do. And what we may be most familiar with is an agitated type of delirium, where the person is pulling at their sheets and they don't know where they are and it's very visible. But what is more insidious is a somnolent type of delirium, where the person is very, very sleepy, but nobody notices because they're not creating a disturbance at the nurse's station, and they're not creating a burden on their time. People don't realize that this is a dramatic change. So what we're thinking about is how can we shift this paradigm and work together to improve care for elderly. So we have on our team Herb Hauser, who you've all met today, but our biophysicist, Robert Spalletta, 2 biomedical engineers, Chris Zegzuski and Ayad Haboubi, We have a computational neuroscientist who works on developing algorithms from massive amounts of data. We have somebody who has developed an eye tracker in Germany. We have a computer scientist, and then people that I've worked with, Mark Foreman, delirium researcher, Sunny Sandhouse. We have a pharmacist and a physician. And we also have student partners as well who worked with us on preliminary ideas with the project and helped us out with our preliminary data from physics, nursing, and psychology. We also have, so you can see our team is rather large. We have the Fraunhofer Institute in Germany, which actually, they develop new ideas. Ramon Huerta is at the University of California at San Diego. Eric Pusey is Medicap Pharmacy and has experience in delivering medications to elders residing at home. We did our pilot at the Jewish Community Center. Jack is from, Pryor is from Nephrology Associates, and we also have involvement with Frontier Communications. So what we're proposing, so in our team, we are in the process of working together. I'll tell you a little bit what our team is about and then what we hope to do. What we are trying to do is build an unobtrusive sensor technology to determine when and how a pill console in somebody's home has been touched. And what we believe is that people have take pills in the same pattern on a daily basis. They take pills in the same way, and that this pill console, which has an eye tracker built into it and also has sensors and a Connect Xbox, will tell us patterns about pill taking, which is a common daily task that requires attention for delirium detection. That pattern of data will be sent over the internet for algorithm analysis, and we will then use each individual's own data to determine when there's a change, and then use that change and to signal an alert to the pharmacist who will supply the pills and to the physician to indicate that something is going wrong in terms of a change in pattern that might be indicative of a change, potential consequence such as delirium. So we're hoping that by working together and working together as a team, I think we can gain new insights from each other and really come up with very different ideas. And the reason we think this is important is that delirium is really presented on admission to the hospital. We really don't know what the natural history is. We don't know exactly when it starts. We don't know exactly when it ends. But we know that early detection is key to preventing the adverse consequences. And so taking pills requires attention. And so assessing pill-taking behavior might be the key. And it also may help clinicians because it changes the paradigm for delirium detection, because we have 20 years of research that says we don't do a great job of it. And we think that we can do a better job and also help people to stay in the home and actually then meet the needs of our growing elderly population. So.
Okay, well, I'd like to take a few minutes to bring up another idea. We've heard a couple good ones, interesting ones here. I'm a chronic disease epidemiologist. Despite what Dr. Ames thinks, I think that's a noble profession. And I work at the Cancer Institute in town, so I'm spending almost all my time in cancer epidemiology, and that was the first subject I thought I would talk about, but I changed my mind as I was preparing my notes for this talk, and instead of talking about a cancer epidemiology, I want to talk about fall in Pennsylvania. I know it's April and it's springtime, and I'm not really delirious. Actually, it's not fall, but I want to talk about falls a little bit. Russ alluded to this. And I'm not interested in just the fall colors or bushkill falls, but I want to talk a little bit about unintentional falls. And to start that, let me tell a story. I want to tell you about Sam and Marie. Now, Sam and Marie are members of that greatest generation, right? Very much like your uncle and aunt, Russ. And they're in their 80s when the story starts. Now, Sam's a decorated veteran of the Second World War. He's a former coal miner. He has a bit of hypertension, a little bit of arthritis, has had one knee replaced, has some chronic lung disease that is either due to asbestos exposure or maybe anthracosilicosis. There's some argument about that. But he lives with Marie in a 3-story home in one of the coal towns here in northeast Pennsylvania. And over time, he'd been getting a little bit less sharp, a little bit of short-term memory issue, but nothing diagnosed. And then one evening in late February, a few years ago, he fell on the stairs. And it was a substantial traumatic injury. He broke some bones in his face, suffered a subdural hematoma, actually fractured one of the vertebrae in his neck, and he was hospitalized, airlifted out of town, hospitalized in a neighboring community, and about 2 months later passed away from complications of that head trauma. So that was his acute illness, his acute presentation. His past medical history included a couple of prior falls. The first one was outdoors, and it was attributed to a little bit of ice or snow on the pavement. Another fall a few months later indoors was attributed to just a little momentary loss of balance. He was evaluated by his family physician. Referred to a cardiologist to rule out any cardiac irregularities, was given a clean bill of health there, and also was seen by a neurologist and had a pretty thorough workup. He had EEGs and CT of the brain, had a little bit of cerebral atrophy, no other brain trauma, no evidence of a stroke, and he was sent home. Actually, I think he might have been on a trial of an anti-seizure medication for a while because there was a thought that there might have been a drop attack, undiagnosed seizure disorder. But despite the fact that he had a prior fall and had been alerted, and the medical system had been alerted to that, his ultimate demise as a consequence of a fall wasn't really changed, wasn't averted. And that was a few years ago. Fast forward a few years, and now Marie, his partner, his wife, is now 90 years old. And she's no longer living in that 3-story house, but she's moved in with her son and daughter-in-law, and she falls. She fell on the stairs, broke 2 ribs, cracked her head, subdural hematoma, twisted a knee. She was in the hospital for a few days, then over to Allied Services for rehab, and has recently returned home. No better, no worse than she was before, maybe. So the issue that I'm bringing up is one that we've already talked about a bit, and Russ acknowledged falls. We alluded to that earlier. Falls in the elderly is a common clinical problem that despite there being a reasonable body of research on what causes falls and maybe what we can do about them, it's still a problem, and I think there's still a need to make some further progress. And maybe our community here in Scranton is not a bad laboratory for working on that kind of problem. So let me just very quickly summarize information, and Russ presented some of this already. About 1/3 of adults in the United States fall every year. It is the leading cause of traumatic death in that population, those over 65. About 20,000 Americans die every year from falls. Now, I don't remember which cancer that makes it comparable to, but it's like in the top 5 cancers or so have that many deaths. The cost has been estimated to be about $28 billion a year in 2010 dollars. And here in Pennsylvania, about 1,300 of our elders die from a fall every year. Consequences of falling, we've briefly gone over these. 20 to 30% suffer moderate to severe injury. Falls are the most common cause of traumatic brain injury in this age group. Other complications are fractures. Certainly we're aware of hip fractures, but spine, forearm, pelvic fractures are also expected consequences of falling. And then there's the fear of falling itself. Once a patient has fallen, they may be afraid of falling again. And that puts them on that downward spiral. They're afraid of falling, so they're less likely to be up and walking, and that contributes to weakening, and that increases their risk ultimately. So there are some very serious or real consequences there. Risk increases with age. I think we recognize that. Women are more likely to be injured if they fall, not necessarily have a greater risk of falling, but they're more likely to be injured. Medications are certainly one potential risk factor for falling, including or in particular polypharmacy. We all know that elder patients with their chronic conditions are treated medically, and they may have 1, 2, 3, 5, 6, 8 prescription medications, and the potential for interaction or subtle impairment of balance or memory or their cognitive alertness may be impaired by drugs. Visual impairment is also a risk factor. Just impairment in balance that may be a consequence of the aging process itself, and muscle weakness are all recognized risk factors for these conditions. What do we know about fall prevention? Well, working on the environment is a good place to start. Reduce tripping hazards. Employ assistance devices, grab bars, railings, and things of that sort. An annual eye exam to make sure that vision is optimal, correct vision when we can. Review medications and limit those that are unnecessary. And then maybe the biggest challenge for this generation, that greatest generation, is to get them to exercise some more. Tai Chi has been suggested as a particularly useful exercise for enhancing balance. Let me say, when I suggested to Marie exercise, she gave me a one-word answer. Bullshit. I'm 90 years old. You can't make me. I don't have to do it. But what are the next steps? I think this might be an issue that there still is room for improvement, for enhanced research to answer some of those questions. Can we do a better job at identifying patients at risk for falls, maybe before they fall the first time and then become afraid of falling or suffer the consequences, including fear of falling, and get on that spiral? And can we do a better job, once we've identified those at risk, of actually intervening in a way that prevents falls? And so those are questions that I'd like to pose to the community here in Scranton, in Northeast Pennsylvania, because we do have an older population. Maybe this is a good place to advance our medical knowledge to study this relatively simple issue. Well, we think it's simple. It sounds simple. I'm not sure it's that simple. Right. That concludes my remarks. Let me ask the members of our panel to come up. We'll sit here, and then we'll open the session for questions and comments on this clinical session.
Sam, before you start, I have a really good idea. After the panel is completed, we'd like to ask Dr. Knipp to go up, make some closing comments, and then why don't we all go to the wine and cheese bar afterwards? We deserve it. That's number one. Number two is a poor substitute for siesta, but it'll do. All right? So
It will have to do.
we'll have to do. We'll force ourselves.
So we're open for questions of any of the speakers in this panel. Yes.
I don't know if I have dementia or delirium, but I can't remember my question. I had a couple of questions for Mary and then one question for the doctor. Mary, where is the palliative care center? It's one of the hospitals?
We see.
Where do you get your referrals and do you have beds available at this country?
We see patients in all the hospitals in the city. We're an independent consult service. So we see patients in every hospital, and we see patients in multiple hospices. And we have an outpatient practice at the Comprehensive Cancer Care Center.
There's no set, I mean, I know
No.
Dr. Vance used to go to the regional hospital.
Right.
But that's not where it is anymore.
It isn't a place, we are a service.
Okay, where do you get your referrals? Where do you get your?
Primary care physicians or the specialists refer to us.
You're involved with all the hospitals?
Mm-hmm.
You have patients in any of the hospitals?
Yes.
All of the hospitals?
Yes. So we're an acute care service just like the nephrologist or cardiologist. So we get asked to see patients in the skilled nursing facility or in the acute care hospital. Wherever they are, we'll see them.
Mostly at the end of life issue. End of life?
Along the way, there's new data, it was just at the National Cancer Conference, there was a recommendation that anyone diagnosed with metastatic solid cancer be advised to have a palliative care consult along the way. So we are a layer of care while they get their medical care at the same time.
Do you follow up, do you stay with them? If someone was referred to the palliative care center, do you stay with them as a physician?
We see them in the hospital, and then we can see them in follow-up as an outpatient.
Continuous follow-up, I mean.
Mm-hmm.
Okay.
There are people we see for months along the way, and then we partner with them, and as things fall apart, that's particularly with cancer patients, but we see some patients with end-stage COPD. The pulmonologist will ask us to see and see along the way while they're getting treatment.
And Mary, isn't it starting to change slowly? It used to be the hospice or palliative care consult didn't come until the patient was in the ICU, 1 foot in the grave, 1 foot on the banana peel. It's starting to change a little bit.
Right.
So you're starting to get calls for non-cancer, like we were
Correct.
talking about chronic disease, and coming sooner.
And some of the pulmonologists locally, when they see a patient, when they get a patient that has a malignant pleural effusion, they will almost automatically consult us to get involved because the situation is more than likely going to be a bad situation. So the earlier we get involved, the more we can treat the symptoms, the better things are going to go along the way for the patient.
And interestingly, some of those patients with stage 4 cancer, haven't they been shown to live longer with
Correct.
palliative care consult?
Correct. Yeah, that was Janet Temmel's work out of Boston.
Mary, can I, over here, can I just ask you to comment on the distinction between hospice care and palliative care, or is that no longer an issue?
No, there's a difference. Hospice is a Medicare benefit at the end of life. Palliative care is what we consider upstream from hospice. All hospice is palliative care, not all palliative care is hospice. So palliative care is good supportive care along the way while someone's getting medical treatment.
So you're continuing to treat the illness even though cure is no longer the expected goal.
Right.
Okay. Dr. Haboubi, you had a question?
Yes, so with regard to when the diagnosis comes to you, requires your the hospice care, is that predetermine the life expectancy to say this person will be able to live up to 2 months, 3 months? Is there a time limit on that one?
In order for someone to enter hospice care, in order for someone to enter hospice care, the patient's primary care physician and the hospice medical director must answer the question, would you be surprised if this person died in the next 6 months? That's the question. There are guidelines under Medicare, under each end-stage diagnosis that has them qualify for that. The problem, as Dr. Stahl said, is far too often the patient life expectancy is a week and they're entering hospice. So the issue usually is not on the other end where they're getting there too soon. We're seeing patients where their life expectancy is hours to days and they're entering hospice. but the qualifications for hospice care as a Medicare benefit, so you're talking about the insurance side, is that they have to have an end-stage diagnosis where the primary care physician and the hospice medical director says their life expectancy, if it goes along in the usual way, is 6 months or less. And the patient can live longer than that as long as, they're showing a decline along the trajectory of disease.
Is it possible to have, is the DNR already been assigned with the end of life, or there's nothing along these lines?
According to the Medicare benefit, and again, this is Medicare setting up the rules, you do not have to be a DNR to be in hospice. Our feeling, though, is it kind of goes against the why are you there and what are you doing? So in our discussions with patients and families, if you want to come on hospice but you want to be a full code, really we need to talk more about what are your goals of care. So it's more about the discussion. Most people, when you talk about that, it does not become a problem. But under Medicare, you can be on hospice and not be a DNR. But it really goes against sort of the goals of care.
Other questions?
Mary, you're palliative care and hospice care, that's
Mhm.
correct? So you need to have that diagnosis of 6 months or less.
I can be doing a palliative care consult in the hospital on someone newly diagnosed with cancer who's going to get active treatment, or I can then go see someone who's in the hospice unit with a life expectancy of 2 days. I can see people in both
You're
realms.
Okay, you're both hospice and palliative care. Okay.
That's because that's what my certification is.
I understand, so
Related to this issue that we've been talking about care and curing, Mary, you may remember the source, but there's a very nice graph. Simple, that is like, imagine a triangle, another triangle, where at the beginning of someone's chronic illness, they may not even be ill from that illness. They have diabetes, no end organ, and the amount of care they need is simply good medical care with a doctor and family support to eat well and et cetera. And then as time goes on, and we continue to do active things, both to manage symptoms and to hopefully improve outcomes, the disease continues and there's less care and less curing kind of care and more care of the person and supportive care. And should never be a point where we say, okay, that issue, if there's nothing more you can do. Like, a lot of times that's what we doctors would do. We would abandon folks at, sorry, I use my hands too much and I'm not even Italian or French or anything, but, where we used to really abandon people at the point where we felt helpless. And the idea being, if we can understand that there's always something you can do to manage a symptom, there's always active things. There might be a reason for someone at the end of life to be hospitalized if you can make them much more comfortable, if you can give the family respite, et cetera. So you never actually stop doing some active things, although more and more of them will be in the house or the hospice setting or whatever.
We can always care for the patient even when we can no longer cure them.
Yeah, and that's really important.
I wanted to ask a question too. Increasingly, both in acute care settings, in outpatient settings, and at the end of life, the concept of who should be on the team has broadened. And some of the best outcomes in various settings are reported where everybody on the medical team is involved, including, medical assistants, nursing assistants, et cetera, and the patient and the family. And I wondered if any of you could comment on the benefits of really considering those folks, the ideas of, frequent huddles during acute care to make sure you notice. It'd be very kind of helpful in the hospital, say, when delirium is an issue or whatever.
For Mary
It's for Mary and for, I think it'd be relevant for everybody, but especially Mary. I'm sorry. Yeah, I think when people communicate, and I think you have to figure out what's the goal, and then who should be on that team. And I think so. It just can't be everybody all the time, because then it's not as focused. But we do have a fair amount of research that says that in places where they have, better nurse-physician communication, in magnet hospitals, et cetera, it works better. But what's interesting is because of this need, growing need, I know of a couple of studies where they're looking at what are we teaching nurse aides, and consider that many of our aides that care for the elderly, we now have this 75-hour requirement that was put in place 25 years ago, and our population is much older and the care is more complex. So I have a colleague in Houston who is like one of the leading researchers on pressure ulcers. And of course, long-term care is a place where we have bed sores or pressure ulcers. And she's working on a project that includes teaching aides. And it's called Take a Quick Peek, and it's not the full assessment that a registered nurse would do. So I think you have to look at what is the context, what is the background of the group, and what they bring to the discussion, the goals of care, and I think, that would be my response to that.
Mario, let him go. Sorry?
Dr. Zane, in terms of the delirium picture, I do a lot of long-term care, and the nurses are eyes and ears of the facility because we're not usually there. So I can tell you that commonly what happens is the patient gets sent out to the emergency room. The nurses don't recognize it's a delirium. It's a change, so that's fine. Patients get to the emergency room, and the issue becomes the emergency room physicians really not understanding that. There's a lot of data to show that there's a real problem in the ERs, so physicians don't necessarily recognize delirium when it gets there. And a high percentage of patients come back to the facility from the emergency room with the delirium. And so it gets untreated, and as you know, it is a reversible problem most of the time, many times induced by us. But if we don't address the problem in emergency rooms, because of the high long-term care population in our area, we're going to have a continuing problem with negative outcomes from delirium. So one of the areas you might look at is how is delirium managed in our local hospital systems, specifically in the emergency room.
I'm sorry, the other thing I was thinking of when we were doing it, I wrote. We talked about this yesterday when we had met. The nurses' aides and the orderlies would be the wonderful people to teach on how to assess for delirium, because they're the ones that are spending the bulk of the time in with patients, and they're the ones who, I think delirium is completely under-recognized. We treat on our service more delirium than we treat anything else, probably more than pain, because they think it's pain and they're over-medicating, it's actually delirium. But the nurses' aides and the orderlies, who are the ones transporting a patient in, a few quick assessment questions to, as you're standing there waiting for an elevator, they could be doing some quick assessment for delirium. And there's an untapped resource.
I think, the delirium problem is huge. I think in the ER, it is huge because people come in, and I'm actually working on a grant now with Sunny Sandhouse that she has, and we're just pulling some charts and trying to track out people known to have had delirium and what happened to them. So yes, it's a huge problem. In this week's New York Times, there was an article that Mount Sinai has a special ER, a geriatric ER, where you have the physical environment, but then also the people are trained. But if you think about it, for our three hospitals in our community, why not all three facilities? Why shouldn't they have a geriatric ER because of the population in Scranton? And it seems like many of the things that you would do are good practice anyway, but it's certainly an untapped area that we need to address. And I do believe that people are cycled in and out because there's something called persistent delirium, and sometimes I think the challenge is for practitioners, they focus on one thing, but delirium is very often multifactorial, and so one item is cleared off, but we don't go and address the second because we think we've done our job on the first.
I have a question. Based on what I've heard in this panel, the goal is to try to have some objective criteria.
To help make a decision whether operate, not operate, palliative care, not palliative care, medical care, not medical care. But what do you do in a case where the patient is suffering from severe dementia? A patient that doesn't know who they are anymore, a patient that can't even function with having a good score on activities of daily living, has a great divide between them and their family. Does that ever creep into the equation? It's not a very, I mean, objectively, you can assess dementia and you can come up with a dementia score. But how does that influence a decision-making process? I mean, you know, Russ, if you had an 85-year-old who was a good possible candidate for a valve replacement, but the person was really suffering from very severe dementia and cognitive impairment, would that influence your decision, or would you just look at it as it's medically a sound procedure to do?
That would influence me. I probably would not offer surgery because, again, my goal is to improve quality of life or to prolong life. Now, that's not to say I've never operated on somebody with mild dementia. So you're getting back to your point of sort of quantifying, if you will, and trying to make some sort of assessment with the help of the family. Can this patient enjoy life? That's difficult sometimes. And I think you hit upon the point that unites us all here. How do we quantify? How do we measure it? How do we come up with tools that are useful? There's different scores in all these parameters, if you will: delirium, dementia, frailty, functional status. But is there a way to quantify aging? You were going to say something. This gentleman.
Oh, no, I had a question. Okay. Oh, yeah. No, of course, my question was related to the woman that you mentioned before. She certainly didn't lose her feistiness when she told you what she thought about your suggestion about exercise or Tai Chi. What I'm wondering about, I'd like to pose this to the panel. There also was an article in the New York Times, 2 or 3 months ago, and it had to do with language and the weighted expectations about people in recovery or people that stay healthy, about the whole question of using the term exercise as opposed to movement. It seems so small, and yet when I think about our lives, incrementally what happens to us as we grow older, I believe, is that we lose movement in our lives. We don't think about losing exercise in our lives, but we think about movement. We have these clickers so that we don't have to get up to turn it down on the TV, but I'm even thinking of simple things like the fact that at one time maybe we did the dishes, or we did things around the household, many things that required us to have more movement in our lives. And over a period of time, we start to incrementally lose that movement. And yet, when we talk about people getting well or the need to stay well, we don't talk about getting movement back in our lives. We talk about exercise. And exercise, I believe, suggests something very different to people than movement. I know when Dr. Javubi responded to the question earlier about sedentary lifestyle, he started to talk about the lack of movement in people in everyday work situations. He didn't say lack of exercise. I thought it was an important point. And so I wonder what the panel thinks about maybe stating the expectations for all of us, including people that are recovering from some kind of an illness, in terms of trying to get incremental, small but important movement back in life, rather than the use of exercise, which suggests that people have to get up out of their chair and maybe go to the local Y, or even do Tai Chi.
Anyone care to comment?
I love your idea. I think that's a great idea.
Well, I think the concept that you're pointing out for us is language can be a barrier. We talk about exercise, Marie's not going to exercise, but maybe she'll move a little bit more.
Maybe show me.
And so there may be, I think there's a valuable message there. Anyone else want to?
I have this kind of ongoing battle with the nursing staff sometimes because, they'll get somebody out of bed to the chair and then they stay in the chair for 6 hours. And we're always saying, it's not about getting out in the chair or getting in the bed, it's you want to move. And we say where there's movement, there's life. And we're always saying this to the patients, even in palliative care. So you want to get up and you want to get out in the chair and get back and get up again. And I'm sure you agree with your post-op patients. So it's not about doing one thing and staying there. And you're kind of working against the forces of staffing and the system. But we encourage patients to keep moving all day, even if it's out for 15 minutes and getting back. And so that's kind of our line, is where there's movement, there's life, and you got to keep moving.
And I would say with the research related to delirium, the initial multi-component prevention studies included, among reorientation and other things, included ambulation. But when they look back at the data, it's most often the activity that gets dropped off because the staff is pressed for time, and that's a challenge. So as Mary was saying, I think that there are now people who are looking at that and really trying to make an effort to do something more than the getting out of bed into the chair, which doesn't solve the problem.
And if there's an issue with staff availability, maybe this is a chance to incorporate what Janet was suggesting, get the family to do some of that. Yeah, I know there's going to be risk and somebody's going to fall and there'll be a lawsuit, but maybe we got to get over that.
I do try to do that, Sam, in post-op patients. So I think the movement has beneficial effects both physiologically and psychologically. So the way I can tell my patients are getting better is when they're moving, when they're fending for themselves.
There's another question.
I was just going to respond. My name is Julie, and I'm an occupational therapist, and I think it's discipline specific, because I know with occupational therapy, we don't go into the room to do exercise, we go into work with people on their activities that are important to them, and a lot of the activity, they're exercising and getting stronger, but you're not using the word exercise with them. I do have patients, though, they will say to me, I want an exercise, I don't want to do my activities when you're in a hospital. So you get both, but you have to work with your clients.
Good point. Dr. Abubi?
I have one more question. It's really, this one is an ethical one, and I know kind of follow the president. Dr. Bailey is not here, which kind of really taught me all the ethics. When I teach my students in physical therapy or occupational therapy, I try to always concentrate on the ethic we have to carry the service. Doesn't matter the person's in hospice or the person in delirium, whatever the reason, we have to continue with the therapy and the treatment. But to Dr. Stoll, I mean, when we decided for this patient, I'm just not going to do the procedure. Is there any ethical committee which would be able to steer us in the right direction to say what we do and what we cannot do?
Understand the question. Is there ethical guidelines, specifically with respect to me, when I should or should not recommend the surgery? Potentially life-saving or life-extending. Is it okay to turn your back on someone because you've deemed them too old? Did I rephrase your question?
Frail. Maybe frail is the word.
Yeah. Well, I believe that physicians have not only the right but the obligation to withdraw if they feel it's futile, and futile could mean no net benefit. But it depends on whose eyes it is. If you try to say to a patient or your family, this is not a good investment of society's resources, that's not a good sell. But if you say to them, I learned this from Mary and Jay, tell me about your expectations. What do you think, mom or dad could be doing or would be doing or should be doing? Tell me what you want. And then you can explain to them that you probably can't meet those expectations because they're unrealistic. They think you're going to fix that valve and they're going to be young again. Very often my informed consent starts with surgery doesn't make you young again. We're going to fix a limited problem. I don't know if I answered your question, but I think there are some ethical guidelines there.
All right, well, let me, at this point, thank the panel. I appreciate you taking these comments. And we have some time for general discussion? Or
Why don't we do is ask Dr. Smith to close us and then have our general discussion.
Very good.
Good afternoon. I'm Brian Kniff. I'm Dean of the College of Arts and Sciences. And I think the first thing I should say is that I really appreciate Herb's strategy of moving you towards the wine and cheese more efficiently. I remember from this morning's research panel that there's something about red wine particularly that helps us in this cause we're all addressing today. So we'll ask you in just a moment to join us in that cause and move forward that way. I want to very quickly thank our organizers, Dan Flynn, who's been here for countless hours today, and our friends and colleagues at the Commonwealth Medical Center. We're very appreciative of your collaboration at these early stages in this process, and we need your expertise, we need your common commitment, and we're just so glad you're here today. Dr. Tavi Miller-Scandal, who you've heard about earlier today, who has done so much of the work to make this possible. And beyond that, in her Office of Research and Sponsored Programs, makes such tremendous efforts to create opportunities for our faculty and our students. I mean, Herb has mentioned the $2.9 million of grants related to these projects this year. There's a lot of work there day by day that Tavi does to create these opportunities for us, and we really appreciate it. And I'm not sure anyone today has actually stopped to thank Herb, but I'm going to do that, who is without a doubt the driving force behind this conference and all of these projects related to it. This time last year, Herb asked me to come to this conference and make a couple of opening remarks. The first thing I'll point out is that today that role was taken over by two presidents. So as a measure of progress right there, we've made tremendous strides. And I think it was obvious to all of us here that Dr. Nora and Father Quinn didn't just show up to be presidential, that this means a lot to them. And they were very thoughtful and very caring in those remarks. And so in many ways, this is coming from the top, and it's important to acknowledge that. When I came here a year ago through 5 inches of rain to what was, a kind of small event, two things occurred to me, and as best I can recall, this is what I said that morning, that, this seemed to me, this first conference a year ago, really a landmark event for our college. And, what was I thinking? It had a lot to do with my idea of the kind of college we are in the College of Arts and Sciences and the kind of university we are at the University of Scranton, that we have this very special obligation to take on the critical needs of the larger community. And to do it the way I think a College of Arts and Sciences and this kind of university ought to do it, by bringing to bear a lot of very different types of expertise. Now, if you want an illustration of that, just think back a few moments to Dr. Zalin's transdisciplinary team there with 6 of our faculty from psychology, physics and electrical engineering, biophysics, occupational therapy, nursing, computing sciences, and then some other little schools in California you might have heard about, some partners in Germany, and all of the regional partners and supporters who are here. That's what we're here to do. And the second point I wanted to make is that, as Father Quinn said so well this morning, we are a Catholic and Jesuit university. And part of that mission, we have a lot of ways of talking about that, and I won't go on too long at the moment, but this is one of the difficult and wonderful things about being a dean in my job is that I have to kind of explain this Jesuit thing to people, including 18-year-olds when they arrive on campus, and we have a lot of really cool Latin phrases for doing that. We have all kinds of things. But the best thing is to show it, you know, and I can't think of very many projects, or maybe any projects, that more transparently illustrate that mission than what you all and our collaborators are doing here today. I mean, there's many ways to conceptualize it. Father Quinn did very well this morning. I mean, we have this idea of, in the words of Father Pedro Arrupe, one of the great superior Jesuits of the Society of Jesus, you know, educating our students to be men and women for others. You know, it's about, as Father Quinn said this morning, learning from people on the margins, from people who are vulnerable, and it's about accompanying them, not just studying them, but learning from them and accompanying them. And it's something more than that, too. It's, you know, making sure that they're not going to be forever on the margins. I mean, I never thought, I'm an English teacher, all right? I'm pretty sure there is nothing in the 19th century novel where you find the phrase successful aging. It is such a very contemporary, different, new kind of way of looking at these things. And it's about saying that, you know, our elders are not going to be on the margins anymore. And that's what we're here, and that's what we're doing. And you know, I'm very grateful for all of you who are helping us to do that. So, you know, there's just one other illustration of what we're about, one other important principle, and that's pizza. And, you know, a little while back, Herb stopped by and said, could you buy us some pizza? Herb, as you might have noticed, has a way of moving things forward. I said, sure, Herb, and then it occurred to me maybe I had to ask what it was for. And it was, you know, we're going to have a little get-together of students. You know, see if we have some students out there who might be interested in aging studies, elder care. So, you know, we bought some pizza, and on a Tuesday night, 5:30 or so, 26 students show up. You know, these are 18-year-olds, 19-year-olds, 20-year-olds, interested in doing research on aging studies. And they were students in nursing, psychology, physical therapy, occupational therapy, physics, biophysics. I mean, these are our students, our undergraduate students, doing this transdisciplinary, let's change the world kind of thing. So keep that in mind, that you are in very many ways, you know, the models for these young people who are, you know, really ready to do things that are extraordinary. So the last thing I'm going to say before I urge you towards that part of the room is we will be back. If I were a little better organized, I'd have more, like I have a date and stuff to tell you, but we will be here next year for a third conference. We will be bigger. We will have a bigger room. I know that was an issue earlier. And to be honest with you, one of the things I wanted to be able to say tonight and tomorrow is we need a bigger room, and we do. We will be better. And what better means is, you know, Charlie Pinches was here earlier, I understand, talking about theological ethics. Trust me, we have folks out there who do philosophical ethics, who are interested in public policy, who are in biology, who are in neuroscience. There are more of us to come from the University of Scranton side. And, you know, there will be more of those other partners. There will be more folks from the community. So I really hope and expect to see all of you back a year from now in a bigger room with more of our collaborators and a bigger, better thing going on. So thank you, and please hang around and join us for the wine, the cheese, and the further conversation. Thank you. Do I do a gesture or something?